So we're going to talk about cancer. And to start with, I want to just introduce what is cancer. Because we've all heard about cancer, and we have a general idea of what cancer is. But there's an actual clinical, and there's even more important, a pathologic definition of cancer. We're going to talk about, we're not actually doing pathogenesis today. We're going to do that on Thursday because it's so complex that I think it needs its own lecture. So we're actually going to do that Thursday. But I'm going to talk about the morphology, and we're going to talk about the etiology and the causes today. So to get started, I'm sure everybody in this room knows somebody or knows somebody who's had cancer. Somebody in the family, a friend of your parents, your grandparents, somebody who's had cancer. So I want you to think about that person and just jot down a few notes, everything that you know about that cancer. What was it called? Where was it found? How was it discovered? And see what was the person's symptoms. Did they receive treatment? What happened? Did they recover? Did they go into remission? Did they end up dying? Are they still fighting it? So write down all of these things that you can think of. So just take a couple minutes.
About it because she didn't work very much, but I know that she went through chemotherapy. She's in remission now. She's cleared of it. But I remember a lot of her going through chemotherapy was like she lost all of her hair, like those typical symptoms. She didn't have any energy. She's got 2 younger kids, so she had a hard time like working through that, like making sure she had time for them and herself and everything. And I don't know too much more about it other than I think she found a lump, the kind of what you think you go and you get it checked.
Yeah. How many people here know somebody who's had breast cancer? Yeah, that's a lot of people. How many of these people, if you know, found breast cancer through mammography or screening? A lot of them. How many found breast cancer by finding a lump one day? Yeah. So there is ongoing debate right now about when people should get screened for breast cancer, whether it should be starting at age 40, starting at age 50, every year, every 2 years. How many of you who know somebody with breast cancer know that it ran in the person's family? So there is a hereditary component to many, many types of cancer. And then the treatment for cancer ranges from surgery. So oftentimes they'll try to remove the tumor, to chemotherapy, which is a cocktail of drugs designed to try to kill cancer cells faster than it kills the rest of your body. So it's not a very specific treatment. Yes?
I have a family friend who was recently diagnosed with thyroid cancer.
Thyroid cancer.
She got the lump removed, but she's going through this new thing where it's actually a pill, so it's not direct radiation, it's a radiation pill.
Right.
Do you happen to know anything about that?
So with thyroid cancer, they can use radioactive pills because the thyroid very selectively uptakes iodine and the rest of the body doesn't. So if you can radio tag iodine, it'll only go to the cells of the thyroid and selectively radioablate those cells. That happens to be very lucky that that those thyroid cells have such a selective feature about them. But that's the goal of cancer treatment these days, is to try to find a very selective way of targeting just the cancer. And There's a lot of research going on to how to do that. Yes?
My roommate's friend from home, his mom passed away from, I'm not too sure what type of cancer it was, but it got to a point where like they tried a new drug, and it was like to arm her antibodies somehow and like make it super specific.
Yep.
Does that work a lot of the time? Or?
So immunotherapy is the hottest, newest kind of branch of research for cancer, and there's several different ways of doing it. One of them is to try to stimulate maybe antibodies to go and attack the tumor. If you can, and there are some cancer cells that specifically make tumor antigens that aren't found on normal cells in the body. So you can try to target the body's own immune system to it. You can do it with antibodies. You can also do it with natural killer cells or with cytotoxic T cells. So these are all, your body is naturally fighting cancer all the time. We all make cancer. Our body is just a natural byproduct of our tissues. But the vast majority of us our immune system will recognize and kill those cells before they can develop into invasive or damaging tumors in the body. So for some reason, it seems like now when a person develops cancer, it's not necessarily so strange that they get the cancer. It's more that their immune system didn't catch it and fix it ahead of time. So how can we get the immune system on board to do that earlier or faster during cancer? So that's another big wave of treatment. What else do you guys know? Yeah.
I'll get that. So my aunt had leukemia, or was they weren't 100% sure.
Leukemia?
Yeah.
Yeah.
They didn't know if it was exactly leukemia, but she was on some pretty hardcore chemo, and her skin was like super thin.
Right.
And she would bruise easily, and sometimes without reason, she would just start, her skin would just bruise.
Right.
She had difficulties breathing, and it was, I don't know.
Yeah.
A lot of crazy, really brutal symptoms. Would that be mostly because of the heart, like the really, really brutal, aggressive chemo she was on, or?
And leukemia is tricky. So thin skin and bruising is often a symptom of leukemia. Because what happens is some of your stem cells will start making only one type of immune cell. And then you don't remember that lineage where we talked about the myeloid lineage? If all of your effort goes into creating one type of white blood cell, then some of those other cells don't get made. So you don't make megakaryocytes, which make platelets. So oftentimes you get bruising because you don't have enough platelets. But at the same time, when you treat leukemia, chemotherapy, the goal of chemotherapy is to stop rapidly dividing cells. Well, your blood cells are always rapidly dividing. It's one of the labile tissues. So that's an important thing, is that cancer tends to be, you're more likely to get cancer in labile tissues because they're constantly dividing. So skin and epithelium, glands, all of those tend to have more, they're more prone to cancer. Now, if it's leukemia, the chemotherapy is targeting those white blood cells, and so you get immunosuppression, you get reduction in the proliferation of platelets, red blood cells, and all of your white blood cells. So I would say that the symptoms of thin skin, thin skin is probably the chemotherapy, but easy bruising is both. It can be both a primary symptom of the cancer and a secondary symptom of the treatment for that cancer. So leukemia is a difficult one. However, it's actually one of the more treatable cancers today, and most people do seem to recover from leukemia. Fingers crossed, yes.
She had it, and then it disappeared, and then about half a year later, it came back even worse.
Interesting.
Does that happen a lot?
It depends what type. Was it acute myeloid leukemia? Yeah, I'm not sure. Cancer does really funny things, and usually it's not that it disappeared, it's that what probably happens, a lot of people, that nobody will ever say you're cured of cancer. what's the term? Remission, right? And that's because there seems to be a pool of cancer stem cells that are really hard to get rid of, because chemotherapy and most targets are going after the rapidly dividing cells. Well, the stem cells are actually more slowly dividing, and they give rise to the rapidly dividing progenitor cells. So it's hard to actually get those cancer stem cells through traditional chemotherapy. But you don't necessarily see them or when you're doing imaging or when you're taking blood counts, because they're not high in numbers. So they might proliferate very slowly for a while, and then they give rise to an aggressive mutation that starts to grow very rapidly. So that's probably what's going on if somebody has the cancer, it goes away and then it comes back even worse. So we're going to talk about cancer is basically an accumulation of genetic mutations. And it goes through a Darwinian process where the cells divide. They're prone to lots of different mutations. If that mutation allows them to divide even faster and even more autonomously, those are the ones that are going to continue to go and survive. The ones that can escape the immune system are also the ones that are going to continue to grow really fast, and that's how you get these aggressive tumors. So let's take a step back. Cancer is a type of neoplasia. So what is neoplasia? Yes, I heard it. New growth. Neoplasia. So this is really any type of growth that is different or abnormal from what the tissue normally does. So neoplasia is a little bit tricky because sometimes it can be intermixed with hyperplasia. But most of the time when we're talking about hyperplasia, at least physiologic hyperplasia, such as the uterus growing during pregnancy, we wouldn't call that neoplasia. That's not a new abnormal growth. So neoplasia is a growth that is different or not supposed to be there. But neoplasia does not mean cancer. So here's kind of a progression of what you'll often see. You'll have normal skin. So this is in the gut. Here are those crypts, normal epithelium. And then for some reason, some trigger, usually it's some kind of carcinogen or exposure to a mutagen, something that causes mutations in the DNA, the cells will start to grow a little bit different. We call that dysplasia. So dysplasia is where they're growing, they're not quite acting normal anymore. They're maybe dividing more frequently. Their size is different, their shape is different. And they don't all look nice and uniform like the normal ones. Now, oftentimes, when you have dysplasia, the body recognizes it, kills those cells, and replaces them with normal, healthy cells, and it goes away. So this is the basis behind Pap smear screening, that through exposure to human papillomavirus, that chronic inflammation can cause dysplasia of the cervix. When they do a Pap smear, that's what they're looking for. They're looking at the cells of the cervix, and they're looking to see if they look anything different from what you expect from normal cells. If they find dysplasia, if they find the cells are a little bit abnormal, you don't necessarily get treatment right away. They're going to start watching it, and you have to get Pap smears more frequently, every 3 to 6 months, depending on the level of dysplasia. Most of the time, not always, but most of the time, you'll see that after a year or two, that dysplasia is cleared, the body has taken care of it. However, not infrequently, many times, the dysplasia goes on to create a neoplasia. So that dysplasia, those cells, here, it's not a new growth, right? These cells are just acting funny in the normal place that they were. But now they start to grow a little bit out of control. So they're not following the normal signals for that tissue. They're growing a little bit new. So we would call that neoplasia. Doesn't necessarily mean it's going to kill you or going to cause cancer. If those cells develop the hallmarks of cancer, which we'll talk about, and they become invasive and they're able to leave this local environment, that's when they become cancerous. That's when they become dangerous. So that's kind of the general progression of cancer. A quick note about terminology. Cancers have somewhat of standard nomenclature, but it's really hard to follow. And you'll find they don't always, there's a lot of exceptions to the rules. So mostly what you'll end up doing is you're just going to learn the name of the cancer as it comes up. But in general, benign tumors have OMA with a tissue type. So if you hear somebody say, oh my gosh, I was just diagnosed with a lipoma, you would tell them, don't worry, that's just a little tumor. It's benign, it's not going to do anything. So lipoma, lipo is fat cells, OMA. Now, it gets a little bit crazy, right? Because carcinoma also ends with OMA. So if it's a tissue type followed by OMA, then it's benign. Fibroma, adenoma, lipoma, chondroma. So these are different types of tissues followed by OMA. The types of cancer are given the name carcinoma if it's epithelial in origin, or it's given sarcoma if it's a solid tumor in origin. If it's a blood cell, we'll call it leukemia or lymphoma. And then there's teratomas, which are cancers of the germ cells. So there's lots of different types of cancer. And when somebody says, yes, question.
What did you say the origin of sarcoma was?
Sarcoma are solid tissues. So sarcomas are things like smooth muscle. You can have sarcoma of the kidneys. Rhabdomyoma is a sarcoma of the muscle, skeletal muscle. Yes?
What's the origin of carcinoma?
Carcinoma are epithelial. And most, not all, but many types of cancers are actually carcinomas. And this includes glands, because remember, glands are epithelial tissue, skin, the renal tubules, the bile ducts in your liver. And I just wanted to tell you an example for lung. So how many of you know somebody who's had lung cancer? Yeah, so lung cancer is still a big problem. But if somebody says they have lung cancer or their grandfather had lung cancer, there's actually a lot of different types of lung cancer. So that term lung cancer is what we use in vernacular, but it doesn't really mean anything to a pathologist because you want to know what is the tissue of origin. So for lung cancer, it could be squamous cell carcinoma. It could be adenocarcinoma. Or it could be a mesothelioma. Mesothelioma is of the pleural lining around the lung. You can get cancer of that. Adenoma is the glands that help secrete mucus around the lung. Whereas the sarcoma the squamous cell carcinoma is the squamous cells, meaning it's probably further up in the bronchial tree. So there's a lot of different types of cancer, and your risk for those cancer is different depending on different exposures. So mesothelioma is most likely to occur in people who have been exposed to fine particles like silica or asbestos. Squamous cell carcinoma is most likely to occur in people who've been chronically smoking. Adenocarcinoma has a familial component to it, but it's also highly correlated with smoking exposure. So keep in mind the different types of cells. The type of cell that's important for naming cancers is the parenchymal cells. So in your reading, you probably read that there's the parenchyma and the stroma. The stroma is just the support network. It's crucially important for the tumor to grow, but the stroma is usually the same in both benign and malignant tumors. It's those parenchymal cells. And the parenchymal cells are the ones that gave origin to the cancer. So are they glandular cells? Are they skin-like cells? Are they squamous cells? Those are the parenchymal cells of a tissue. Those are the ones that become transformed and can become very aggressive. So that's what we name these tumors after. Any questions? Yes?
Like I've heard of things like carcinogens, like are there sarcomagens?
Oh, that's a good question. So carcinogen, actually that term itself refers to anything that can cause cancer. So it's not specific to any type of cancer. It just means it can cause cancer. Most carcinogens are mutagens, meaning that they can cause mutations in the DNA of cells, and depending on which cells are exposed to those carcinogens, those are the ones that are going to go on to form cancer. So we all know exposure to the sun is correlated with skin cancer. So sun is a carcinogen, and it affects the DNA in your skin cells. Yes?
So my grandma has skin cancer and it keeps coming back, and now it's gotten to a point where like her skin pigments are all gone. Is
Okay.
that like a common thing with skin cancer?
So the question is, with skin cancer, the skin pigments have gone.
Yeah. Just throughout the entire body.
It must be pretty deep. So your skin pigment happens at those basal cells within the epithelium. But if those basal cells, maybe there's a mutation that prevents the production of pigment, of normal pigmentation. But I'm not sure exactly why that occurs. Yeah. Yes?
For lung cancer, did you say it's only for, or not lung smokers, but can you get it from smoking weed? I know you can get it from tobacco.
Yes. So the question is, can you get lung cancer from smoking weed? And the answer is yes, because what you're doing is you're combusting. Yeah, we know the real reason. But you're burning chemicals. So the process of burning any kind of plant, not just tobacco, creates carcinogens. When you have a fire in your fireplace at your home, there are carcinogens in that smoke. Most of us are still going to have fires or go camping and stuff because it's the direct exposure to high heat and combusted organic molecules that is carcinogenic. So, choose brownies, I guess. No. Okay. So, a very important question, whenever you feel a new growth, if there's ever a neoplasm, is it benign or is it malignant? Benign means it's very unlikely to kill you. Malignant means it has the chance to cause severe damage and kill you. So that's why we care. Benign tumors can still grow quite large, and you might want to get them removed. There's a lot of women who have leiomyomas, which are a benign tumor of the smooth muscle of the uterus. But with those tumors, they can't get pregnant, they can't carry a baby to term, So it can still have a lot of problems associated with it, but that tumor itself is not going to leave the uterine wall, and it's not going to kill the host, the person who has it. So the distinguishing features between benign and malignant, there's really 4 main features. And you can kind of see these when you're looking at a pathology slide. So a benign tumor is going to grow slowly. That's why, when you're told to check your moles, if it starts to change really fast, then you start to worry. If it doesn't change fast, it's maybe growing a teensy bit every year, then you're not as worried about it because it's more likely to be benign. Same thing for prostate cancer. So what's the screen for prostate cancer? What's the screening test that your dads and granddads should be doing? So colonoscopies for colon cancer, PSA, yes, prostate-specific antigen. This is one of these tumor-specific proteins. It's only produced by cancerous cells. So what doctors look for, the reason they want you to start getting your PSA measured regularly in middle age is because they're looking at the rate of change. If a man has a PSA of 1, it doesn't tell you much. If he had a PSA of 0.3 last year and he has a PSA of 1 this year, it tells you a lot. That's really important. That's a big, big jump. And that's when you're going to start doing biopsies and try to figure out if there's actually cancer in there. So it's that rate of growth that's really important. Under a microscope, if you're looking, one way to measure the rate of growth is to look for the number of cells that are dividing. So that's how many mitoses there are. So in a benign tumor, you don't see many frequent mitoses. The cells are dividing, but they're dividing slowly. So the chances that you happen to catch one on your histology image are pretty slim. Whereas for rapidly growing tumors, those mitoses, you'll probably see several of them in any given field because those cells are constantly dividing. The degree of differentiation is also really important. The most aggressive tumors that are malignant, you can't even tell what cell type they used to be often. That's called anaplasia. So anaplasia is the loss of any distinguishing feature. Yes?
Why can it go from benign to malignant? Because my cousin just died of brain cancer, and at first they thought that it was just like a benign because it didn't grow for a couple of years, and then it grew like really big.
Right.
For like 6 months.
And that's a good point. So when we say if something is benign, it's not likely to kill you, it means it's very unlikely to become malignant, but it's not impossible. So, and it depends on the different tissue types again. Like very, very rarely does leiomyoma in the uterus ever turn into anything malignant. But in the brain, you can have what seems like a benign tumor because it's very well defined. It's a glioma, so it looks just like other glial cells. It's just growing in a mass. So it looks very benign, but it's maybe 1 or 2 mutations away from becoming malignant. So it's a grayer area than your book would like you to believe. But yeah, we tend to try to make these distinctions. And pathologists, again, they're going to hedge. They're going to say most likely benign. They'll never give you a report that says, oh, this is benign, don't do anything. Because we just can never say that for sure. So these are general. The other thing is, these are guidelines. These are features, but it's not hard and fast. It doesn't mean that what you're looking at necessarily is benign, even if it has all of these features. So sometimes something might be labeled benign because it has the features of a benign tumor, but then it causes cancer out of nowhere. Well, it actually wasn't a benign tumor after all. So the degree of differentiation of the parenchymal cells, that means how much do they look like their original cell type? If you're talking about gut epithelium, how closely do those new cells look like regular gut epithelial cells? The best feature, the most important one, is this right here, whether it has a well-defined border. So pathologically, when you're looking at something, if there's a capsule completely surrounding the tumor, that's very likely to be benign. If you don't see any tumor cells growing away from the tumor, then it's likely to be benign. So a well-contained, with very defined borders, any tumor like that is most likely benign. That's because cancers, they've developed invasiveness. They've developed the ability to grow beyond their borders. That's what makes them dangerous. So it's almost like a feature of, it's a definition of the feature itself. And then benign tumors won't metastasize, whereas malignant tumors can metastasize. It doesn't mean they will, but they have the ability to metastasize. And that's the goal of cancer treatment and screening, is to catch cancers before they metastasize. What does metastasis mean? Yeah. So I hear lots of, it's basically to spread to a new tissue, a new place. So with breast cancer develops in the breast. The first place that it usually metastasizes to are the lymph nodes. So it goes to the axillary lymph nodes. If it's with breast cancer, knowing that is really important for treatment, because if the cancer has already spread to the lymph nodes, now you have to go start looking for other tumors throughout the body. If it's maybe only in one lymph node, or if it's completely confined to the breast, you can do surgery and radiation without chemotherapy and feel pretty good that you've gotten rid of the cancer. So metastasis is a very important predictor and driver of treatment. So it's a predictor of treatment outcome and a driver of treatment choice. And when we talk about pathogenesis on Thursday, we'll talk about the features that give a tumor the ability to metastasize. So here's just a quick schematic. This is a figure from your book to look at the features. And they chose the uterus to look at, so a leiomyoma. Again, this is a smooth muscle tumor. It happens in the wall of the uterus. On this side, you can see that this tumor is very well contained. It's got clear borders. When you look at it under the microscope, these cells look a lot like smooth muscle cells. And you don't see any mitotic figures in this picture right here. So that is pretty good sign that this is benign. Now, if you go to the other side here, this is a leiomyosarcoma. Sarcoma is, again, solid organ cancer. So this is of the smooth muscle of the uterus. And now when you look at it, you see some cells that still look like smooth muscles here, but a lot of cells, they don't look like smooth muscle at all. Smooth muscle are those long spindly cells. These are round. You can see some of these cells have their nuclei in the process of division, so they're undergoing mitosis. And there's what's called, they're heterogeneous. The size of these cells, like this is quite a big cell here, and this is a little bitty cell here. Some of the nuclei are really dark. Some of the nuclei are small. Some of the nuclei are big. So there's a lot of disorganization in this tissue. Yes?
So at what point, like if the tumor
That's a good question. When will you notice this tumor growth? So some people may just have really bad cramps during their cycle. And, there's a lot of causes of that. So we don't do a lot of routine screening for leiomyosarcoma is actually a pretty rare type of cancer, whereas leiomyomas are pretty common. But oftentimes it would be more likely to be diagnosed during a woman's trying to get pregnant, having difficulty or having frequent abortions, spontaneous abortions. They might go and do some imaging. You might have imaging done for some other reason, like a lot of women have digestive problems and they get a CT scan and lo and behold, there's a tumor in your uterus. So the symptoms are pretty nondescript. If you have a lot of spotting, that would be something to go get tested for, because the leiomyosarcomas, part of aggressive tumor growth is a lot of angiogenesis, but then the tumors will outgrow their blood supply and necrose, and you'll end up having a lot of bleeding associated with it. Yes?
Just like curiosity, what's like the toughest form of cancer to fight?
What's the toughest form of cancer to fight? That's a really difficult question. I think that one of the most dreaded cancers is pancreatic, because pancreatic cancer does not have a lot of symptoms. So you can have a tumor growing and you don't realize it until it's gotten past the point of being able to surgically remove it. It's invaded your blood vessels. It's metastasized to the liver. And pancreatic cancer tends to be more anaplastic, which makes it more aggressive, where the cells have de-differentiated, meaning they've gone back to being more stem cell-like, which allows them to grow out of control. And we don't have any good specific treatments for only pancreatic cancer. Like, there's certain types of cancer. The most aggressive type of breast cancer is actually very responsive to, we have developed a very specific chemotherapy for it. So even though it's really aggressive, it's highly amenable to treatment, whereas we don't have that with pancreatic cancer. So a question over here, and then I'll come back to you.
Okay, so my grandma was diagnosed with pancreatic cancer after they found a couple ulcers in her body.
Mm-hmm.
What does that have to do with that cancer?
Do the ulcers have to do with the pancreatic cancer? Probably not. Although chronic inflammation associated with an ulcer could cause blockage. You remember that the pancreas, the duct coming out of the pancreas, joins with the duct coming from the bile, from the liver, the bile duct, and then goes into the small intestine. That early part of the small intestine, the duodenum, is also a frequent site of ulcers. So if you have chronic inflammation from an ulcer in that area, I could see that might clog up the duct, and that could cause inflammation in the pancreas. Inflammation is a big risk factor for any type of cancer. So I'm just kind of going off the top of my head here. I don't know that for sure, but that would be my closest mechanism for how to link those. If they're related, oftentimes people have gastric ulcers for a lot of different reasons, and that could be completely unrelated to the pancreatitis or pancreatic cancer. Yeah.
So it's kind of like when it comes to like differentiating between like benign and malignant tumors, like I'm a little confused, like when you're looking at a gross anatomy, like how to differentiate between the two.
Okay, good. So yes, it can be. So the question is differentiating grossly between a benign and a malignant tumor. I'm glad you asked that. I planted Alex there to move us on. Okay, so here's a lipoma. How are we doing on time? I always run out of time. Okay, is it okay if we just keep going so we get through this? Good. But you think this is benign or malignant? Benign. So one clue is the name, right? A lipoma. It's not carcinoma, it's not sarcoma, so it's most likely benign. What else? What gross features show you that it's benign? Yeah, look at that. Doesn't it look like you could just go in there and kind of pluck it off and it would be gone? So it's very well contained. It has clear borders. Look at those borders. That's pretty smooth, right? So it's not like it's kind of wrinkled all over the place. There's no projections coming out of it. It's a pretty smooth border. So size is not a distinguishing feature. The other thing is if this is a piece of skin cut open, and here's the fat. So this is in the subcutaneous layer. Lipoma is actually the most common neoplasm among people. So if you feel a little round ball under your skin one day, it might be a lipoma. And you just kind of keep an eye on it. And if it grows very slowly, it's probably completely benign. Let's look at another one. So here are leiomyomas. This is a uterus. Here's the cervix. Here's the uterus, and it's cut open down the middle. So this is a leiomyoma that was cut in half and spread open. Here's some leiomyomas. So this person had a lot of these neoplasms. But you can look at them. They look very well contained. When you cut into this one, it looks very homogeneous. There's not a lot of different colorations or shadings. The tissue doesn't seem very disorganized. It seems quite similar to normal tissue. It's just an extra big growth. Now here, this is ductal carcinoma of the breast. So this is a surgical specimen that was removed from somebody with breast cancer. And it's really hard to pinpoint the borders here. So the white, this is the tumor, and the kind of yellowish stuff is the normal fatty tissue of the breast. The tumor is more solid, but there's no clear boundary, right? They often like to use the word stellate for starlight, these projections going all out. So the tumor is probably about here. Why do you think they took out such a big piece? To make sure they got it all. For clean margins, that's always the goal, is to get clean margins with surgical excision. So they want to know that if they look out here, there aren't any of these anaplastic cells or any of these malignant cells way out here. Because most likely, even though grossly you only see it out to maybe this far, there's projections that go much farther than that, where the cells are starting to grow beyond their borders. Here's a renal cell carcinoma. So what features of this image make it look more like cancer and less like a benign tumor? Yeah. Right, it does. It's all these red spots are actually areas of necrosis in here. As the tumor grows faster than it can make more blood vessels, it outgrows its blood supply, it gets hypoxic and starts to die. So you have these areas of necrosis in here. You have areas over here that are a little bit whiter looking, and you have areas over here that are a little bit more solid looking or fibrous looking. So it's heterogeneous. Even though it has kind of a border around here, within the tumor itself, there's no clear border. There's no way to, it's not well defined. Yes?
This whole thing a tumor?
This is the tumor. Yeah. This whole thing is the tumor. It is cut open, yes. You're seeing the inside of the tumor. Yes.
So, like, if the entire part is a tumor, like, it looks like the edges are kind of, like, smooth and rounded out, like, that makes me want to
kind of. So I see what you're asking about, but look right here. So here's the tumor is cut away here, but here's also the backside of that tumor. And it's not very smooth. And it's homogeneous in texture. It's homogeneous in color. It's
Oh, okay, so there's all kinds of different colors.
there's all different colors.
Like straight parts.
Yeah, if you were actually using a gloved hand and you were palpating along here, you would notice that it has kind of a rough feel along it. It doesn't have that nice, smooth, clean feel. Was there another question up here? We're good. Okay. So let's look at microscopic images. So a lipoma, that tumor we saw the first picture, when you cut it open, here is the lipoma. So this is the skin, and the lipoma is nested right here. So the pink lining along here is a fibrous capsule. That fibrous capsule is usually derived from around it. It's kind of like the surrounding tissue walling off that area. If you blow it up, all of the cells inside of here, that's exactly what fat cells look like. So they don't have the pleomorphism, the difference in size, the difference in nuclear staining that we saw with the leiomyosarcoma. You don't see any mitotic cells in here. So these are well differentiated, meaning they look a lot like the cell they derived from, the fat cells. They're not rapidly dividing, and they have a smooth border. Whereas here is ductal cell carcinoma. This is from the breast again. And if you look at it at low power, this is the tumor right here. But look, there's a little satellite tumor right there. So, and you can just kind of let your eyes zoom out a little bit and not focus. It just looks very disorganized. Here, there's some fibrous tissue, some stroma. These are, they're glandular-like cells, but they're not forming real glands in here. They're just kind of haphazard all over the place. And now, let's zoom in and look at some of these cells. So here's that fibrous tissue. Here are those glandular cells. So all of this stuff that's not cells, that's the stroma, the support network. And if you look at these cells, they're trying to form glands a little bit, but they're not forming real glands. Remember, real glands, you would have a ring with a lumen. So here there's a kind of a ring, but the cells are then next to these other cells that aren't really participating. They don't look like true glands. And I should have put an image here of what a real gland looks like. So the things to look at are the size of the cells and the size of the nuclei. Are they all uniform? Are they all the same? And in this case, look over here. Some of these cells are really big and some of these cells are much smaller. Some of these nuclei are stained really dark and some of these nuclei are barely stained at all. Partially that's because they're at different stages of the cell cycle. And I'm trying to see if I can see any mitotic figures in here, but I'm sure if you were to look carefully, you would see mitoses. Look at this. These cells right here, they're almost all nucleus. So that's another important feature is that you can, to try to quantify it a little bit, you can look at the nuclear to cytoplasmic ratio. And if the nuclear to cytoplasmic for a normal cell, it would be 1 to 5 maybe. In cancer, it'll be 1 to 1 to 1 to 3. there's more of the cell taken up by the nucleus than by the rest of the cell. So that nuclear to cytoplasmic ratio can be a good clue as to how much anaplasia is in the tissue. So does everybody kind of see these cells, how much nucleus there is compared to the rest of the cell? How the shape of them, some of them are kind of squashed. They're not all forming these nice square cells that you would normally see. All right. Okay. And so when you look at the histology and the gross images, you kind of get a feel for how malignant, how dysplastic, or how anaplastic any given tissue is. And we generally know now that cancers tend to follow a course. Sometimes people will say it just came out of nowhere. Well, it's not that the cancer came out of nowhere. It definitely started with some kind of dysplasia, but it changed so rapidly that the first symptom was a massive malignant tumor. So I'm going to save this because we're going to talk about the progression, the steps to go through to get to cancer in a few minutes. Okay.